Christophe has been working on India's demography for a long time. In the 1980s already, he worked at the Madras Institute of Development Studies. He worked also at the Institute of Economic Growth in Delhi, as well as at the École Française d'Extrême-Orient in Pondicherry, before completing his PhD in Paris on India's historical demography. In the early 2000s, he was based at the French Institute of Pondicherry, where he published mostly on fertility decline in South India. In the last 10 years, Christophe has largely focused on prenatal sex selection, starting with India and China, and later including Southeast Asia, the Caucasian area, as well as Southeast Europe. He has written more than 10 monographs on gender-based sex selection, and he is also the author of the first global report on sex imbalances at birth, which was published in 2012 by the United Nations Population Fund. He recently contributed to the UN Population Fund's report on harmful practices. His last co-edited volume was published in 2016 and was entitled Demographic Transformation in China, India, and Indonesia. More recently, Christophe has also conducted research on mortality associated with COVID, which will be at the heart of today's presentation. Today's presentation is based on a paper which was entitled An Alternative Estimation of the Death Toll of the COVID-19 Pandemic in India, which was published just 2 weeks ago by PLOS ONE. The title of today's presentation is COVID-19 in India, Figuring Out How Many People Died, How Many Died. So again, I would like to welcome Christophe for this talk this evening. Thank you to all of you for being here. Just a quick note before I let Christophe start. We have muted you during the presentation, but there will be a discussion by Chinmay Tumbe following this, whom we are very happy to welcome. I'll introduce him later. And after that, we will welcome all your interventions for Q&A session. So thank you, Christophe. The floor is yours.
Thank you, Lawrence. Good evening and good morning to everyone. My presentation, as you've understood, will focus on COVID, the experience of COVID mortality in India. And it's going to be slightly technical, but I'll try to focus on one of the most interesting points in this work. So the next slide will show you, maybe we should go full screen. Will give you an overview of what I'm going to present today. So first, I will give you some ideas of the world perspective on COVID mortality, and then I'll get back to India and see what we had in India in terms of available statistics and how we can compute the death toll of the COVID pandemic in India. And what I'm going to do here is to detail an alternative approach to mortality estimation using different samples, including one from the Indian Railways and another one drawn from Kerala's statistics. And I will conclude by presenting you the result of my estimation procedure, and also to draw some comparison with available data from other parts of the world. So let me start with COVID in as it was 6 months ago, the number of deaths that were recorded across the world. So these are the official numbers. And as you see, India doesn't stand out, compared, for example, to the US or Brazil. Or even you can see a concentration of COVID deaths in Europe, especially in Western Europe. You can maybe distinguish the UK, Italy, France, and Spain. But of course, the number of deaths due to COVID are to be related to the overall population. And so when you compute the COVID death rate, you see a different picture emerging. The higher rates are observed in Europe and also in North and in Latin America. And you have lower rates elsewhere, and in fact, very low rates in Central Africa or in China. But I started working on COVID 2 years ago, immediately after coming back from Delhi. I was, in fact, I reached Paris 2 days before the lockdown, so I had just a little time to pick up a few things from my office room in Paris. And there I was in my apartment for the next 3 months. So I used the available data to look at the age distribution of COVID deaths. And this is something that was at that time available only for a few countries in Western Europe and in Northern America. And when I did that, I realized that COVID death rate by age tend to project a very clear picture of a linear relationship between death rates and age. So on these different charts, which measure male mortality for COVID, you can see that with age increasing, the mortality due to COVID increases gradually, but very, very distinctly, because you always have a linear pattern. And the same is true also for female COVID death rates. And this was not indifferent to my research. And in fact, that's how I started publishing the first part of my work on COVID. And it was completely unrelated to India because we had very few data at that time on India. Even if you can see India here, these were only a very small sample that I took. But what we understood is that COVID, since it was closely related to the age structure of the population, then we should expect that countries with a greater share of old population were to be more affected. So what statisticians do in such cases is to standardize death rate. That is, they apply the death rates, but to a population with similar age structure. And that's what we did. And for example, if you look at this map, you have standardized COVID death rates. That is, for example, you see that death rates are still high in Western Europe, but they are not as high as before. Why is it so? It's because we have taken into account the fact that the elderly comprises a larger share of the population in Western Europe. But Latin America still stands out very clearly, and you can see also Mexico, you can see South Africa, and Iran. Comparatively, India is still in a very average position, but remember that these data are based on official statistics. Now, this is what I did when I was in France, and a little bit later, I moved to India, and that was almost a year ago in March. And I think I was in Delhi, and I don't need to tell you what happened then. That was my second lockdown, just a few weeks after my arrival. And again, there were stories coming up from everywhere about infections and death. And for the first time, I was directly affected with two friends who died in South India, even though they were taken care of by a very good hospital, Chitmer in Pondicherry. And then finally, a neighbor who was supposed to come for dinner and canceled at the last minute. And 3 days later, she was dead. So I realized that this tragedy was of a different scale from what I had experienced in France. And lots of people around me told me the same story, that they knew people who not only had been infected, but who died during this period. So I got back to the statistics and I looked at what we had. And usually mortality data for COVID are classified, of course, by cause of death, but also by age, sex, locality, day, date, and comorbidity. But in India, we had only very limited information, like the one I'm showing, where you have the number of cases and just the number of deaths. You know, one number per day per state, and with no detail about the sex or the age of the deaths. So I started re-examining this data. And then what we discovered, I say we, that means me and many colleagues working simultaneously, is that there were a serious risk of underestimation in India. And they were due to different factors that I've listed here. The fact that people could not recognize COVID symptoms, that there was not enough testing to confirm that deaths were due to COVID, that there was reluctance to report COVID deaths because people were really embarrassed and afraid of the consequences, that there was reluctance also from local or regional authorities to publicize COVID deaths because it was a matter of political shame. And then on the top of that, there is a tendency to under-register deaths in India, sometimes by more than 30% in parts of North India, for instance. Now, what happened was very interesting later on. We saw journalists trying to identify COVID deaths on the ground. And for example, Divya Bhaskar, the edition published in Ahmedabad, was the first to offer ground level analysis of COVID. And what they did is very simple. Is that they took, like, for example, on this line, you can see Rajkot, the city of Rajkot in Saurashtra in Gujarat, where you have the number of deaths, which they, in 2020, from March to May, and they compare it with the number of deaths recorded in 2021. That was done so in May 21. And they discovered that there were almost 8,000 excess deaths, whereas the official number of reported deaths due to COVID was only 288 in Rajkot City. So these street level demographers, if I can call them this way, forced us to re-examine mortality, and by using another technique which consists of comparing trends with what you observe in a given year. So for example, here, you can see what is observed every week in the US in 2020. And here are the trends. And so what lies in between correspond to excess mortality. And this can be done in the US, for example, here, it's for a specific population group. We may not have such refined, precise data in India, but we do have numbers of deaths registered. Now, the idea is basically that COVID deaths can be computed as a difference between observed deaths in, say, 2021 and earlier deaths observed, say, 1 year earlier or 5 years earlier. This is not exactly as simple as that, because the difference between observed and expected deaths could be due to other deaths, or they could miss also deaths that were in fact delayed by COVID. For example, during the lockdown periods, there were less road accidents, so there were in fact less deaths due to that. But there may be also other deaths that were related to COVID, such as deaths due to the collapse of the medical system, but that are not technically caused by coronavirus. Anyway, in India, we have our first challenge, which is the fact that deaths, as I said earlier, are often under-registered and may not be published. That mortality is declining, so it's not stable. So it's difficult to compare 1 year with another one because they may not be at the same level. And that we have only patchy data, so we have to balance what we have with what is missing. For example, there were very few data available for North India. And then, of course, there is a more complex interaction between COVID and other causes of death. So I decided to follow a different path. So what I did is that I used different subpopulations for which we have very good quality data and see what happened to them during the COVID period. To do that, I had to review existing samples. This is a technique that we use in historical demography. So here I'm giving you just a couple of examples. For example, in France, there is a study that monitored the population whose family name starts with TRA. So these are a couple of thousands of families in France, and they are being followed from the beginning of the 19th century. In Chinese demographers are using, for example, genealogies from the Ming period, for which we have good data of date of birth and date of death, and also marriage. So there are many different sources like that. And it's a typical approach in historical demography when you don't have civil registration data. So what I did was to look for samples in India. And I had to follow specific criteria. First, the sample must correspond to a circumscribed population that I will use as denominator. I need to have also reliable estimation of their COVID deaths, which I'm going to use as a numerator to compute the death rate. I need samples that are large enough. I need, of course, good information on age and sex structure, because remember, the risk of COVID mortality is closely related to age. And I needed also samples that were, for which we had data over 2 years, up to 2021. And ideally, they should be representative at the all India level. So I screened a couple of samples, which I discarded because they were not usable. For example, Indian Armed Forces, which is a very good quality. But unfortunately, we don't have enough information about the age distribution, and it's very crucial because Indian Armed Forces soldiers are on average pretty young, around age 30. So that's an age where COVID death rates are low. So, but we don't have the exact age composition. And so I reviewed a lot of samples, which I couldn't use because they were not precise enough, or too small, or not representative of India's population. And finally, I selected 4 samples, which I'm going to present in greater detail later on. So one is political personnel, if I may say so, MLAs. Another one is from the statistics of Kerala. Then there is one based on Indian Railways staff. And then finally, a small sample which I'm using for final validation based on school teachers in Karnataka state. Now, when you look at the MLA sample, it's a very small sample, but it's of very high quality because we have the age, sex of each member of all the regional Vidhan Sabha, that is the regional parliaments. And we have their names and date of birth. And we have also information about their deaths. So we did a search to identify all MLAs, and we included also MPs from the Lok Sabha and members of the Rajya Sabha who died before end of May 2021. And when you look at the date of their deaths and the distribution on the chart that you can see, you see that the distribution of their deaths is very close to the distribution of the deaths in according to official statistics. And so I've provided some other information. Now, one issue regarding this sample is whether it was representative of India's population. So one thing is sure is that we had MLAs from all over India. But then this group is an elite group that benefits from a lot of privileges, not only high salaries, but especially access to medical facilities. And in fact, we realized that a vast of COVID deaths affecting MLAs took place in the most reputed Indian hospital. That shows that we were dealing with upper middle class. Yet, at the same time, this population was subjected to a very high level of exposure to contamination. I mean, some of them initially denied, the risk of COVID, but they had a lot of political duties, especially during this period, because if you remember that last year political events didn't stop through the pandemic. There were a couple of elections in 5 states and Panchayat election in Uttar Pradesh. And these elections, in fact, have been blamed for the spread, for the diffusion of the coronavirus in North India. I mean, blame, but we don't have exact proof, and I'll tell you later why. So in conclusion, I believe that this population had probably enjoyed much better medical access to medical infrastructure than the rest of India, but at the same time, we are very much exposed to the pandemic, probably more than anybody else. I mean, more than the Indian population on average. So maybe one factor offset the other one. The other sample I used is based on the Indian railways. So it's a much larger sample. We had, in fact, almost 2,000 deaths by beginning of May 2021. But we have also some interesting characteristics for this sample. One is that they have a very good health system, so which means that probably COVID deaths were pretty well registered. And another factor is that several unions called for compensation for COVID deaths early on. And so it must have acted as encouragement for families to adequately report cases of COVID deaths. And we have also enough data to reconstruct the age structure of the Indian Railway workforce. And another thing is that you find Indian Railway personnel all over India, except in islands or mountainous region. You have also socio-economic groups. You have even lower status groups thanks to reservations. So probably it was a slightly more privileged group than the rest of the population due to different characteristics, but still it's a large enough one to allow for estimation. So what we could do at this point was to compute the death rate for these two populations. But the trouble is that the death rate applied only to adult populations. For example, the population working for Indian Railway is aged from, say, 20 to 60. You don't have young people, obviously, you cannot be employed, but you don't have also pensioners. So how do you convert the death rate of the adult population into a death rate for India's entire population, including the youth and the elderly? That's where we use the Kerala sample. The Kerala sample is the deaths that were recorded in Kerala and that have been regularly published by the Bureau of Statistics of the state of Kerala. It's in fact a unique database in India because I haven't been able to find anything comparable, including in Delhi or in Mumbai or in advanced municipalities or in any other state. Kerala is also known as a place where you have high quality demographic data. So when you look at the Kerala COVID dashboard, you can even find the list of individual deaths due to COVID, including with the name of people who have died, which I think is a matter, a privacy issue here. But otherwise, you have it for several thousand deaths with their age, place, and date of birth. So I use that to compute death rate by age and sex, which you can see here in black on these two figures. I compare them with other death rates by age and sex, which I computed for different countries. And I was, in fact, surprised by the similarity with the death rates computed from Sri Lanka. And Sri Lanka happens to be, in many respects, a country pretty close historically to Kerala. So it's interesting to see this. But for me, it meant something else. It meant that these data from Kerala were pretty consistent with what we found elsewhere. Of course, the level was different. For example, you can see that the level of deaths in Brazil was apparently much higher than in Kerala. But nevertheless, the profile of mortality by age was comparable. Then what I did was to model the death rate by age, and here I'm going to skip the detail, but I'm using a rather complex modeling where I use 4 parameters in order to account for the specificity of the death profile by age. The level, the age gradient, the specificity of old age, and the specificity of young age. So that's what we call quantum for the intensity of death rate, tempo, which is the age schedule, and then you have 2 other factors for adjustment, which is for young age and for old age, because it's not exactly linear. So I'm using that to model mortality by age in India, and then I will apply that to the death rate that I've computed from the MLA and from the Indian Railway samples. So finally, this is what I did in a nutshell, is to use Kerala, that you can see here, for the modeling of mortality by age, to use different samples to get the intensity of mortality among adult population, and then finally get a picture for entire India, and also standardize the results for comparison. So here is what we're getting. So if we use the estimate up to the end of October, according to this method, we get 3.2 million deaths from the Indian Railway sample, and slightly more, 3.6 million deaths from the MLA sample. So this means a correction factor compared to official statistics by a factor of 7 here, factor almost 9 on the MLA sample, which is in fact pretty comparable to other studies that have been conducted. So 2 of them have already been published. And so there is one published just a month ago by Science to see the results from around 3.1, 3.4 million deaths. And then there were other studies which have not yet been peer-reviewed, but they provide also estimates ranging from 3 to 5 million deaths. So on average, this is what you get, what below, you see 3.7 million, which is quite close to the estimates from my work. Finally, it's time to look at, to go back to Kerala and see, remember what Divya Bhaskar published, and see what you read now in the press in Kerala, in Gujarat, sorry. Well, we have to add some bits. Now we read in the press that was a month ago that in fact the number of COVID deaths claims is several times higher. I mean, 7, 8, 9, according to state, higher than the official numbers. So that tends to confirm that in Gujarat, in fact, the number of COVID deaths was seriously underestimated. So in India now, we think that the undercount ratio, that is the number of estimated COVID deaths compared to the official death, is 6 to 8 times the official number. You can compare it with the one in the Russian Federation, almost 7. Belarus is much higher, but even South Africa, it's a factor of 3. Egypt is very high, and Peru is almost 2 as well. Now, if we go back to the numbers, to the standardized number, we see that finally the standardized COVID death rate in India is much higher than in the US and even higher than Brazil, the one I used for comparison, which was so high. In fact, India's COVID death rates was probably higher. So from what I know, and I've not done a systematic estimation on that, India is the number 2, just below Peru's rate, because Peru is probably the most affected country, the country most affected by COVID. So as a conclusion, I would like to draw your attention to 2 points. First, we can use indirect procedure to compute new estimates of COVID mortality. And now there is an overall agreement that we are talking about 3 to 4 million deaths and not 5 lakh deaths as per official estimates. And our method using very specific samples tends to agree with this range. Maybe we are a little bit below, probably because our samples was more privileged than the rest of the population. Now, there are large gaps within it, and these are questions that I still cannot answer. For example, the exact contribution of each COVID-19 wave, the unequal impact of the pandemic on different socioeconomic groups, especially the poor, the unequal deaths across regions, because here we have only a consolidated estimated number for India. And even more important, it's not possible at this point to assess the role of national and regional policies, testing or lockdown, and their impact on COVID mortality. That's all. There you will find more information in the publication in +1, and otherwise I welcome your question after Chinmay's intervention.
Thank you very much, Christophe. So as you said, before we open the floor for questions, we are very lucky to welcome Chinmay Tumbe as a discussant for this paper. Let me introduce Dr. Tumbe. So Chinmay is assistant professor at IIM Ahmedabad. Before this, he was international visiting scholar in business history at the Harvard Business School. He also taught at Tata Institute of Social Sciences in Hyderabad, and he has recently published The Age of Pandemics, 1817 to 1920, published by HarperCollins. So Chinmay, the floor is yours. Thank you. I think we need to unmute. Sorry, just give us a second. We will just unmute Chinmay.
Just type this in. Yes,
yeah.
Very good.
Yes, thank you for giving me a voice. Fantastic presentation by Christophe, a demographer I hugely admire. And this, I must say, is one of the most ingenious studies of very clever ways to estimate COVID mortality in India using sample groups. The Indian Railways, who would have thought that you could look at the Indian Railways to estimate or make some use of deaths, or the Kerala data, or for that matter in the paper, the Karnataka school teachers data. So congratulations for this excellent work. Christophe has also pointed out to different studies. I am a co-author of the paper published in Science, so I have been actively involved in this project of getting some sense, as the title today is oriented about figuring out how many people died. I'm going to talk more about placing this work in the larger context of what we know about mortality in India, mass mortality events, and so on. And I'm going to have just 3 or 4 slides just to place this in context of history, because for those who don't know, Christoph has contributed tremendously to historical demography in India. So I'm going to start a bit with history and then come to the present. You'll have to just enable participant screen sharing. Yeah. So just to place mass mortality events in Indian history, this is a chart or table to just give you a sense of some of India's worst disasters. How bad is COVID? That's the question to start with. If we accept Christoph's numbers of 3 to 4 million, where does 3 to 4 million get you in Indian history? Well, it is one of India's worst mortality disasters ever. Obviously, on a per capita basis, not as lethal as, say, some of what's happened in the past, because India's population is 4 times larger than what it was in the early 20th century. But India's worst disaster in recorded history was the influenza pandemic. 20 million people estimated by some, 1918-19. In a way, very similar to what happened, broke out in Western India. The second wave was much more lethal than the first wave. Just remarkable similarities, a bit in geography as well as in terms of the synchrony of waves in what happened in 1918 and 19 as to what happened in 2021. Now that was huge. If you believe 20 million, that's about 6% of India's population knocked out. So that remains India's worst disaster ever. You had plague spread out over 25 years. You had famines, which were there. But when we say a number like 3 to 4 million, that gets you in a way into the top 5 disasters in Indian history. And clearly something which should not have happened in a way in the early 21st century, given the tremendous advancements in science and technology that has happened since then, right? So influenza, plague, and some of the great famines of the past, or the terrible famines of the past, have taken a lot of people. When we come to 1918 in particular, right, what we really see is what we saw, the brutal second wave that happened in India, which really caused a lot of havoc. All of us were witness to that last year. And all of us will actually see now, the one-year death anniversaries will begin from April, and you're going to see a massive, if what Christoph is saying is true, what we're essentially going to see is 3 to 4 million one-year death anniversaries going to be mourned in April and May, because bulk of the mortality happened in April and May this year. And we're going to see those advertisements in newspapers coming forth in the months to come. But if you see the comparison, this is just reported mortality. It has all the problems of under-registration and so on. But the chart on the left is in the years leading up to 1918, and the chart on the right is the years leading up to 2021. And you see the pandemic mortality, the signature, right? You see what a pandemic does is essentially unsettle monthly death rates. You'll see monthly death rates are typically fairly similar across time. And what the pandemic does is to double, treble monthly death rates. That's what really it does. And that's what really happened last year in the second wave, where by different estimates, the all-cause mortality of India doubled over a quarter. That's probably the simplest way to understand just the sheer shock of the mortality. Another way to put this is the fact that in India, about 25,000 people die on a daily basis because of something or the other in usual times. If indeed 1,000 people were dying off at its peak, 4,000 people were dying on a daily basis in May last year, reported by the government through COVID, you would not really see the kind of havoc that we were seeing, the pressures on the crematoriums, the cemeteries. If it was just a 10% additional mortality on a daily basis, you would think your supply chains of dealing with dead bodies would be sorted pretty quickly. What essentially a figure like 3 to 4 million tells you, and especially when the bulk of it came in the second wave, what it tells you is that India was witnessing on some of the days of April and May last year, more than 50,000 deaths daily, a doubling of the usual 25,000. Right, and so that's why this complete discrepancy between the COVID deaths and the figures that were the kind of ground level reality of last year shook everyone. Intuitively, the official numbers last year very quickly became a public joke. And just like Christopher said, journalists played a pioneering role in first setting the ball Dainik Bhaskar, Divya Bhaskar in Gujarat, a lot of newspapers on the ground kind of led the way. Coming back to now the studies about what is the value, what is the utility of studies like these, and what can happen in the future. I'll just take you through a bit about 1918. This is a table which summarizes all the studies that have estimated mortality of India's greatest demographic disaster. And if you see, when the British officials first put a number to influenza mortality, they had it at 5 million. So how many people died in the influenza mortality of 1918-19? And the British said 5 million. And the first guy to question that was a census official in 1923 who said, look, it's not 5 million, it's much more than that. It could be as much as 12 million. And over the next 100 years, you'll see so many studies which have revised those figures upwards and upwards using different methods, but none as ingenious as what Christopher has done here. Essentially, the methods to calculate deaths in a pandemic revolve around two. One being what we call as the excess mortality. That is, you look at death rates and say how many more people died in a given period. And second being what is called as the intercensal population growth rates. That is, if we have a census today, and if we have a census in 2031, and if we have a census in 2041, we can estimate to a certain extent using either the entire population or age cohorts, the shortfall in populations. Because what Martin in 1923 found was when they went to enumerate people in villages, they found massive depopulations, 10 years after they had gone from 1911. So that's the other way to know shortfalls in population is through the census. So typically studies on the 1918 pandemic have looked at excess mortality using the registered death certificate kind of based data and census. And Christo's study is in a way unique because it breaks away from many of the standard methods, which including our study did using excess mortality, and using a completely innovative and new way to understand mortality in India, which is to use the population groups and to see the validity. And if you read his work carefully, it's very, as with all his work, he's looking at what is this group all about? What is it that could actually be higher? For example, the Indian Railways data, yes, they have better access to health, but then on the other hand, during a lockdown, many of them were not exposed to the general population. So there's stuff going both ways. For example, the MLA data on politicians, they are more exposed to populations, but at the same time, they have the best of healthcare facilities. And that's the kind of careful kind of balance in which, if you read Christoph's work, comes out very carefully. I'll kind of quickly wrap up now just by pointing out some of the stuff that's come out from our study. Our study also, apart from excess mortality, we did have a survey which directly asked a question on COVID. And you'll see basically what it found was this massive spike during the second wave, right? So this is in a way, the only survey which asked a question throughout the pandemic period of, do you have any member in your household who died of COVID? And you see what happened in April, May last year. It again doubled from the standard death rates that we're observing. And when you look at the actual government figures themselves, you again see the massive uptick, what happened in April, May last year. And this is data coming from the government health management information systems, which, for example, we used in our study. So to put it more broadly, Christoph works adds very huge value because it's looking directly at COVID deaths, right? So for example, when our study came out, the Union Government of India came out with a myths versus facts kind of a circular saying, first, that the study is not peer reviewed. So that's the first thing we should praise Christoph's study for, because now one of the complaints of the Union government so far was that all these studies on COVID mortality in India, none of them are peer reviewed. Well, we now have 2 papers which are peer reviewed. Second, the critique of the Union government is that, these methods are faulty. For example, excess mortality, how can you say it's COVID? Maybe it was something else. What Christoph's work does actually is to very directly say, look, this is COVID. We're looking at COVID deaths. These MLAs in our sample died of COVID. So it's a very direct way to ascertain COVID mortality. Yes, there are, of course, challenges in extrapolating from any small population to a larger population, but that's what essentially Christoph does, and he does it very nicely. In terms of the last point, which is cross-country comparisons, I'll just qualify some of the stuff Christoph said, partly because Christoph's study ends roughly in the middle of 2021. I think USA has been hammered in the last few months. So if you update the cross-country tables, I think USA is really badly hit in the last 4 months by COVID. So if you look at per capita COVID death rates, even excess mortality, USA is really badly hit. So it's the difference that you're showing in your table now. By now, the USA has also unfortunately caught up to India's standard. And the other country which people don't really talk about too much is Russia in terms of the pandemic. If you look at excess mortality figures, and if you believe these studies, India is unfortunately number one at more than 3 million. Russia is number two at more than 1 million. And then it's the US at about 1 million. Right? So in excess mortality, in absolute terms, it's India, Russia, USA. That's the pecking order as it speaks. And on a per capita basis, then Russia is actually probably the most hit. Again, if you compare, if you standardize it by age and stuff like that, you might get countries in South America which are more hit. But I do think the Omicron wave in particular was much more deadly for USA in particular than many other countries of the world. Finally, in terms of response, you would think that such studies would prompt the government of India to conduct its primary way of ascertaining deaths in India, which is what is called as a sample registration system. That's the one thing which can tell us a lot of information on deaths. Unfortunately, India's primary way of ascertaining death rates was stalled. The 2019 numbers were really not out, 2020, 2021. So the primary way in which we usually ascertain deaths in India has not been done for 2 or 3 years of the pandemic, which is very unfortunate. And hence, we have to rely on studies, estimation exercises like what Christoph has done, because there is nothing else out there which says the same story. And finally, I just end by saying that the utility of this study and studies trying to get somewhere a sense of truth to the idea of how badly India is affected is very important to also correct a particular narrative which seems to be emerging that India has done very well in the pandemic. The vaccination story has been fantastic since June last year. India has vaccinated a huge part of our population. But in the overarching scheme of things, India is one of the worst hit countries of the pandemic. And if we do believe actually a narrative that India is not hit, then unfortunately we are not going to invest in better statistical systems to report deaths. And we're going to make the same mistakes. And in future, if another pandemic wave comes as bad as the Delta wave, we again will be shortchanged in understanding what's really going on. So the moral to take, as the concluding slides and the paragraphs of this paper suggest, is that India needs to have a much more better and revamped death counting system in place, which is transparent, which is timely. For example, the vaccination data of India, you can access at the level of a second, because we have a vaccination dashboard. You know exactly how many people are vaccinated at any given minute in India. But we have to wait for 2 years to find out how many people died in India in a particular district. So that's the kind of massive difference in statistical dissemination on core indicators. You would think births, deaths are core indicators on which we need very timely data. And we have the architecture for that data. Unfortunately, the pandemic has made a lot of state governments of India paranoid about releasing this data. And across the political spectrum, there seems to be a very strange silence of not really disclosing the data, or not, for example, doing surveys which can elicit the data much more comprehensive. So when the union government says that these studies are flawed, the counter argument is that, well, then do your own study. But that's what the union government of India has not done yet. And I think that tells the bigger story. So I'll stop here and I think over to the other interventions.
Thank you, Chinmay. Are there some questions that you would like to ask Christoph in relation to his study, or should we just let Christoph answer to the comments that you made? I know that there will be questions coming later, but maybe
no, I think let others ask. Yeah, that's fair.
Okay, Christoph, do you want to? No. Okay. Okay, great. So I can see that Nicolas Gravel wants to ask a question. I think that Bina Agarwal also put a question in the chat box, if I'm not mistaken. Bina, since I think you posted your question first, would you like to unmute yourself and ask your question yourself?
Yeah, this was just a clarification because Christoph said that the pre-vaccination period he counted till May of 2021. Technically, of course, vaccination started in mid-January, although for selected groups. So I was curious how the May 2021 was the cutoff point that he used.
And maybe we can also ask Nicolas Gravel to ask his question like that. Christophe can take both questions at the same time. Nicolas, we will just unmute you.
Sure. Can you hear me?
Yes.
Okay. Yeah, so thank you very much for this nice presentation. I just had perhaps a clarification question. I'm not sure I understood what you did with the Kerala data. If I understood correctly, for the whole state of Kerala, they do have a registration system that record and report both the age and the gender or the sex of the dead people in the whole state of Kerala, or not. And I suppose also that you have the age and sex structure in Kerala for the whole state. So then, I mean, I was wondering why. I mean, because estimating your model, which estimate the probability of dying of COVID on the basis of age, sex, and a few other things, the model that you very quickly went over, which you used to do your extrapolation, you could have estimated in Kerala and then projected to the whole India. Perhaps you have done that also, but I was just wondering whether there was some difference in those, in these estimates obtained on the Kerala data, which in my view would be much more representative of the whole Indian situation than, the specific sample of Indian Railway and MLA that you have used more importantly. So I guess this is just a clarification question about what use you made of the Kerala data. I mean, I may have misunderstood something. Thank you very much. Very nice presentation. Very nice work.
Okay, thanks for your question. So first I'll respond to Dina. What I wanted to avoid is to follow up these two samples I had, MLA and Indian Highway personnel, after May, because this is when, for example, among the highway, the information I got, this is when they introduced very active vaccination campaign. So in that sense, they would be even more privileged than the rest of the population. Because you may remember that the share of the population that had been vaccinated in India by May was very low, even though a vaccination drive started in January. And in fact, when it picked up, that was in May and June, there was immediately a shortage of vaccine. So that's why I wanted to restrict it to earlier period. Of course, it's not exactly correct, since, as you were mentioning, vaccination started earlier than May. But it was still limited to a very small part of the population, at least for double vaccination. And then regarding Nicola, we can compute the situation of Kerala based on their data, but this is not something I was interested in, because I think that Kerala is not representative of India. In fact, we may say, as a rule, that Kerala is never representative of India. And in terms of its health policy during COVID period, we know that Kerala followed a different path and was identified early on as providing a different kind of support. So why I'm using Kerala? I'm using Kerala to have the first picture of the age gradient of mortality in India. And using this gradient, I'm going to adjust my model so that it fits the death rate observed among the adult population of the railway workforce and the MLAs. That's the idea, to use a pattern, a mortality pattern, that is not coming from the US or from Brazil or even from Sri Lanka, but coming from India. And then I will adjust it to what we observe in the different samples I'm using, including, by the way, the school teachers of Canada.
Thank you for for these first questions and for your answers. Christophe, we have two more questions in the chat box. So one by Bruno Dorin and one by Mary John. Actually, I think it's a question from Satish Deshpande. Mary John, would you like to read out the question that Satish Deshpande has posted, and then we will ask Bruno to also ask his question. Okay, so it's the Satish Deshpande actually who's speaking. Yes,
Satish, you were muted earlier. We sent you a request. You can click on the button to unmute yourself. Otherwise, I will be send the request to unmute.
We will ask you to unmute again. Maybe we can ask Bruno to ask his question in the meantime. And Christophe can take both questions at the same time. Bruno, would you like to ask your question? Bruno, I'm not sure. Okay, let us do one thing at a time. So first, Bruno is also, I think we have to unmute him. Okay. Just give us 30. Yes,
Yeah,
great.
can you hear me?
Yes, we can. Please go ahead.
Yeah. Sorry, I have to leave soon, but thank you, Christophe, for this very clear and convincing presentation as usual. I had just in your preprint of your paper that I read in details 6 months ago, your estimates were about 2.2 million persons by late May 2021. And in your 22 plus papers that I just downloaded, it's approximately at least 3.2, so 1 million more. Okay, by early November, so let's say end of October. So I was wondering, does it mean that there were at least 1 million additional deaths in 5 months, June to October, according to your estimates? Or was it also maybe to fit better with other studies that came into picture? And if yes, how this later phenomena within science, I mean, we always try to fit others' estimates, could have play or come in this exercise.
Christophe, sorry, do you mind if we just let Satish ask his question? Sorry for interrupting you.
Okay. Thank you very much, Christophe, for this wonderful presentation, and this is a real teaching paper, I have to say. I teach a paper on quantitative methods, and I would love to teach your stuff as very, very clever ways of indirect estimation. I just wanted to extend this effort and pick up on the gaps you point out towards the end, and wonder if in an effort to make this kind of effort, your kind of methods more durable, whether we could work out systems of controls for the various limitations that you mentioned, in particular for regional variations, regional differences. So as you know, you pointed out yourself, Kerala exceptionalism is a problem. Can we find a set of indicators which if we put together in some way that will allow us to compare states, like the efficiency of their health system measured by particular indicators, density of healthcare services, and so on. I'm just speculating. So would there be a way of making this kind of way of indirect estimation portable across time and across contexts?
Christophe, if you want to.
Maybe I can respond immediately to Satish. I would say that maybe, and here I'm going to repeat something that Chinmaya said. The first principle for a good statistical office to work is transparency. And transparency means that data are being shared, and they are being shared as soon as possible. So whether it's a matter of 1 day or 1 week may not be that important, but it is in fact. And whether data are openly available, disaggregated, so we can immediately identify gaps or issues, and so the system will self-correct automatically. And that's what we have with Kerala. I'm afraid to say that we can even see the names of the disease, but that's one way for people to even correct the thing and say, no, it's not, on the list. There was Dr. Thomas who died in Trivandrum, so maybe he didn't die that day, so they can correct it. So that's what we should aim for. And Kerala is showing the lead, but there may be other municipalities ready to do that. I thought Mumbai would do it, but in fact, they are not yet at this level. So transparency plus rapidity of sharing information, and that would probably, create a new environment in which, and I mean, this is again the story of Kerala, and here it's a personal story. 15 years ago, I was in Trivandrum, and I read that people were complaining about the quality of death rate estimation in Kerala. And I thought that, oh, I'm no more in India. What is this? People are discussing about the quality of death rate estimation in this state, when in other states, and I'm not going to mention any, we just don't know. We just don't know what is the actual death rate. And I mean, the number of deaths are still today not being published regularly in several states, and states with several crore inhabitants. So the distance is huge. Kerala is showing the lead, but we can imagine that other countries, other states like Punjab or Bangalore or Karnataka or Tamil Nadu, for example, can simply emulate the experience of Kerala. Now, coming back to Bruno, this is a pretty technical question. Ever since I did my first, I published my first estimate, but that was in June or July. My paper was submitted, was updated and then again updated. And the final version that you've seen must have been prepared in December. So in December, I wanted to have the data up to October. I mean, that was the latest period for which I had the data from Kerala, or which I was able to model that. So I used end of October as a reference period, whereas before the reference period was end of May, as far as I remember, or mid-May. So that's why you see a gap, because by end of May, the second wave of COVID in India was not yet over. In fact, it was over by, say, September, October. So that's why you see a much larger number of deaths. That's the main thing. Thank you anyway for both of you for the question.
So thank you for your questions. I don't think that I see more questions in the chat box. Will anyone? Okay, I think that Aprajita would like to ask a question. Please.
I'm sure nobody else.
And if anyone else wants to ask a question, please feel free to raise your hand or leave a message in the chat box. I think that Ines also wants to ask. No, okay, sorry. So Aprajita will ask a question, and then we will open the floor to more questions.
Thank you so much. So I'm going to start off with something that Chinmay also mentioned, that so everything about the last 3 years would eventually be conjecture, but conjecture of who is going to make which kind of methodology more transparent. I mean, some studies will be more transparent than others. So in that context, ground level demographers, as you said, they play a very important role. But how do you systematize, or how do you take them seriously in terms of methodology? Is there a way to think about this period as a period where you actually take seriously ground level data? It's not just civil registration data in that sense. And in that, and of course, that offsets a lot of historical problems also, because the way famine was, I mean, David Arnold has written about the way famine was defined, and how people try to de-escalate the numbers that families were bringing in right from the census. Anyway, so there's that. If that question is not clear, let me know. The second question is about all of your samples are government servants of one kind or the other. What about like laboring class, non-contractual populations? Is there any way of recording that at all in this scenario? And again, that links back to your ground level demographers, whether they might have. And essentially, it's a question of methodology. How do you cover these two gaps?
Before maybe Christoph answers this question, so I think that Chinmay has raised his hand. So Chinmay, would you like to unmute yourself?
Actually, more in the line of a comment to some of the other things that were said. One, the Kerala sample, it's important to actually have it until October, because the second wave unfolded in Kerala actually between June and October, and not in April and May, as all of us know. All the TV channels were going on for about 4 months about how Kerala is the epicenter of COVID, but that's because they had contained it in April and May, and as they slowly opened up, the Delta variant came. So if you look at the data just for May and just for Kerala, you're not going to see anything actually, and that's why I can understand why this 1 million difference comes, because you're looking at Kerala. Most other parts of India, though, the virus ripped through April, May, and the bulk of the mortality, there's no doubt in my head that it happened in April, May. But Kerala is different. A lot of that mortality of the second wave actually happened between June and October. And the first was also point of vaccination. If anything, vaccination would actually increase the estimates, in the sense that these samples, if the MLAs were vaccinated and so on, these death rates are then the floor. And that's why I think you should see the 3 to 4 million number as a conservative lower bound estimate. It could well be much more. And that's something only which the SRS or the census can establish with, I would say, a little bit more certainty than some of these estimations.
Thank you. Christoph, would you like to answer these two questions and comments?
Well, I think the role of ground level demographers is crucial in the democracy. They are the guys who are, at least that's what we've seen in India, who were the first to be able to demonstrate the huge gap between official numbers and what was observed on the ground. People look at civil registration data, but they, if you remember, they went also to crematoriums to get a sense of the number of people cremated every day. That's what they did in Delhi. In UP or in Bihar, they started counting bodies floating or people being buried along the rivers. So they provided a sense of the fallacy or the incompleteness of official numbers. Now, I don't think that that we can take the numbers much further, because however well they may be organized, they cannot compete with the statistical system. They will still miss people who are not being cremated but buried. They will miss people who are actually not, whose body is not floating somewhere. They will miss deaths which are not reported in the municipality. So, and there is not much they can do. So I don't think we can expect more from them than the role of whistleblower. But I think it's absolutely crucial, because this is what I was telling about Kerala. It's a conversation between civil society and statisticians, and everybody has to come to an agreement. And the media people play a crucial role in this conversation, I believe. Something that we have not seen in other countries where there is high level of under coverage, like for example in the Russian Federation. Now, otherwise, I'm completely in agreement with what you say about the fact that some of the samples I've used tend to underplay the fate of informal workers and specific sections of the workforce. And that's why I would agree with Chinmay that such estimates are the lower floor of estimates, and that the real numbers are probably slightly higher, but how much higher is something I cannot say at this point. Thank you, Fred.
Do you want to answer Chinmay's comment? I mean, you have already commented on it, but no?
No, I'm totally in agreement with Chrissy's comments.
Okay, I think that Bina Agarwal has another question to ask. Bina, would you like to ask your question?
Yes, I think I'm already unmuted. This is actually a question to Chinmay. Since he got this historical evidence from the 1918 influenza pandemic, I haven't done any kind of detailed work at all on this, but I did look at the, the Government of India, the Sanitary Commissioner's Report 1920. And one of the things that, it was a little nugget, it was striking that it mentioned that although overall mortality was much higher for males than females, but in certain age groups, which was it was 20 to 40, it's a reproductive age group, the female mortality was higher than male mortality. And there was an increasing little aside in that, which is, of course, that they were both more vulnerable, but also that they were, one could say they were much more exposed because they were doing more care work in the home. So the viral load probably was higher because they were caring for the sick. We haven't, so the question is that, is there in the Kerala data, because it's age and gender and everything else, has there been a comparison? Christoph, have you done that? And is there any such insight that's possible? Of course, Kerala took care of the pregnant women as well, so I'm not sure that it would show up, but it could show up in broader statistics if you look at less privileged populations. The other thing which struck me in the Sanitary Commissioner's report of 1920 was that the low caste groups, the death rate was 61.6 per thousand in Bombay City compared to something like, I had these figures ready, so I'm saying that is 18.9 for upper caste. So these are just markers that, how important it is to actually do a much more disaggregated analysis. But do either of you have any insights at all, even from small, whether it's Kerala or the railway workers analysis?
I'm going to talk about Christoph's work because I've read his paper very closely. One of the things he has out there is that station masters' death rates was twice as much as the other railway workers, which I think is something he didn't mention in today's presentation, but is suggestive that exposure in COVID, differential exposure is something which people are going to be researching a lot in the next few years, but it's going to be very tough. But I think that's something, I think Christoph's last slide had that. Different socioeconomics groups' exposure to COVID mortality is something, unfortunately, there's literally no study on. There is some data on Gujarat compiled by journalists. It's called the Gujarat COVID mortality datasets. It's freely available. You can download the spreadsheet. It's got, I think, 64 municipalities data, and it does mention the occupation of the person. But it's very messy data, and it's not something. But it does have age, sex, and city-wise data from Gujarat. But otherwise, to the best of my, there's a data on Chennai published in the Lancet, which is on Chennai Municipal Corporation. And they, I think, say that some neighborhoods were more affected based on acids. I think the broader picture was that the poorer were more affected. I think that's one paper on COVID. I just take a minute on 1918. You're right that the COVID mortality, the influenza mortality was huge by caste. But a part of the 1918 puzzle is that there was the flu, but the flu also came on the back of India's third worst recorded drought in history. So it was flu plus massive distress, food prices going through the roof. And the flu came in September, the second wave, and 4 months before that, there was a massive drought. So a lot of that mortality was also through malnutrition. I don't think that's that much of a incident in the COVID scenario. I don't think you'll find such massive differentials between social groups, I think, in COVID. That's my gut hypothesis. But I think that was something unique about 1918, the drought and the influenza combination. On gender, 1918, I find it very inconclusive actually. There's a paper by Vishnupriya Gupta. They find no real difference between men and women. There's a PhD student at IIM Ahmedabad who's working on this question on gender and the flu. So that's still a research project.
No, you're right overall, on average.
Yeah.
What struck me was the 20 to 40 age group.
Yeah.
And you find the same in the Great Bengal famine, that if you break it down by age, and which I did, you actually find that that's the age group among women who are the most vulnerable. And there are other issues of anemia, and as you say, if the station masters are dying, I wonder what happened to their wives with the viral load. So it's a question of sensitivity of how we also push for more, not just more granular analysis, but more granular data, which is what both of you have been arguing for.
Over to Christoph.
Well, I don't have much to comment because I would love to have disaggregated data and be able to measure them. The only thing that is almost systematic, and not only from Indian data, but across the world, is the male disadvantage. And so we see in India higher death rate among males at all ages, by a factor of, say, sometimes it's 20 to 30% higher, might be even more, much higher among older age groups. Surprisingly, it's something that is still not well understood. The reasons for that disadvantage. Is it just a biological factor, or is it one way or the other related to exposure to the infection, or the lack of care received by men? So that's still an open question. But I will look again at the Kerala data, in fact, with your question in mind, to see if we can make sense of this imbalance between men and women regarding COVID mortality risk. Thank you for this idea.
So thank you. I think that we do not have another question. Oh, sorry, very quick. So maybe we'll have one more question and then it will be time to close the session. So Tista has a question.
Yeah. So it's a very clarification question. In your log linear model, you are talking about the correction factor of 7 or 8.6 for the between the official estimates and the MLA estimates. But in your initial slides, you saw that their distributions are very close. So that close of a distribution resulted in a correction factor of 7, or because the correction factor seems huge, right? Or am I misunderstanding something? Because
yeah, well, the thing is that it would be very difficult to know whether this undercount level was the same over time.
Okay.
So what I did for the MLA is that for the MLA, we have the date of death. So we can compare the distribution of deaths by date with the official statistics in the MLA, and they are similar. That's what I'm stressing. Now, it doesn't mean that the level, intensity of mortality is similar. It is not, in fact. But with the Indian railways, this is something I wasn't able to do because we don't have the age, the death distributed by date. So I cannot compare that with the official data. But it has been done in Chiang Mai study, because they have the data from a survey, so they can plot the distribution of deaths by week and compare it with the official statistics. So it's possible, but not from my data. Thank you.
Thank you.
Thank you.
Is there any other question just before we close the session? No? So before we close the session, let me warmly thank again, of course, Christoph, for this wonderful presentation. I would also like to thank again Chinmay Tumbe for this really interesting discussion. You really brought in many more elements. And it is time now to announce the next session, which will be a workshop by Laurent Glatry, who is at Humboldt University. The talk would be entitled National Heritage for the New Nation, a post-independence history of the archaeological survey of India's conservation policies. And Dr. Hilal Ahmed from CSGS would be the discussant. So thank you again for this wonderful discussion. Thank you all for your questions. This has really contributed to the discussion, and we will see you very soon.
Thank you. Goodbye.
Thank you, goodbye.
Ça se fait pas d'applaudir. Mais quand même. Yes.